delirium tremors.
Absolutely. That's the same that of SIWA, the SIWA that I was mentioning. Absolutely, you have to do it. How often? Sometimes it depends on the hospital protocol. ¿Qué dice ahí, Joan? What does it say about how often do they recommend it? Does it say anything about the time? Let's see for the SIWA. Severity, it doesn't say time, like I said, because I think that varies based on the hospital policy. And remember, the Nclex doesn't ask you about policies that a hospital has in specific, but it will tell you like a generalize what applies for everybody, because obviously they cannot independently pinpoint what every hospital wants to do. Great job.
All right, let's go to the next one. The nurse's emergency department is observing a staff member caring for a client who experienced sexual assault and is awaiting for arrival of the sexual assault nurse examiner. It would require follow-up if the staff member is observed. Which one of the following? Inquiring about the day of the last menstrual period and the use of contraceptive. Instructing the client to put a gum and place the clothing in a biohazard bag. Administering prophylactic medication for sexually transmitted infection, and moving the client from a waiting area to a private room.
Very good. So sexual assault. All right. It would require follow-up. So obviously we're looking for something that is incorrect. Highlight the follow-up part, porque a veces se nos olvida.
Yeah, which one have follow-up?
So let's see, inquiring about the date of the last menstrual periods and the use of contraceptives. That could be indicative, that could be okay, ¿verdad? Because we got to find out if there's a risk that she could end up pregnant because of this sexual assault. Instructed the client to put on a gown and place the clothing in a biohazard bag. I don't know. I don't know about that, because remember...
Put a gown for what?
A gown, like to have her remove the clothing and put on a gown so we can examine them. I'm not mad about that part. What I don't like is the fact that of putting the clothing in a biohazard bag. Because remember, this was an assault. So they could be proof, right? Forensic proof. They could be DNA in the clothing of that patient. And she's going to be examined by a sexual assault nurse who has experience in forensics and how to collect forensic evidence. So if we put everything in a biohazard bag, we might be either contaminated or maybe, I think the proper way to put this is like in, like as evidence. And you should make the person remove her clothing, but we usually put even on the floor, you put like a big mat. So in case that something falls, if dirt falls off or hair, because the person can have hair from the attacker. And remember, all of that could have DNA proof because this is a crime. So eventually this can go to court and all the evidence that we collect can be used on that case. Let's see third. Administering prophylactic medication for STIs? Absolutely, right? We don't know what is, right? What do we think about number 4? Moving the client from the waiting area to a private room.
I think it's indicated, right?
Yes, absolutely. They just experienced assault. So since that is indicated, we're going to remove, because remember, we're looking for what's incorrect. So yes, I would choose number 2.
Perfect.
Great job. Absolutely. And the reason why, as I was explaining, we need to collect evidence. So this patient needs to, when this happened, ideally they should call the police right away. Even though they feel like they need to clean up and take a shower, they should not take a shower. They should not remove the clothes. We need to swab underneath their fingernails. We need to try and collect as much evidence as possible from their body, right? Because they're going to have evidence from the person who assaulted them on them. Obviously, we need to provide privacy. We need to provide, this is one of the patients that you need to provide a lot of emotional support. This is a very traumatic event. Obviously, police and the authorities need to be notified because this is a crime. We definitely need to test for pregnancy. We need to test for STIs. We need to test for HIV, and we need to offer the client all the prophylactic medications to prevent, because we don't know what this person, right? We don't know the history of this person who assaulted them. Odds are that if you are assaulting someone sexually, you probably are not going to use protection. So not only there's risk of pregnancy, there's also risk of contracting a disease. Very important. So it says right there, yes, it's very important that we tell the client to not, to not clean themselves until we have collected all of their clothing. And again, the clothing need to go in bags that are specific as evidence.
All right,
Very
let's move
good.
to the next question. Okay, someone want to read?
Who wants to read the next one, guys? No? I can read it, Joan, and then
Okay,
you can
thank
read, and
you.
then we change. The nurse is planning care for a client with anorexia nervosa. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. We're going to monitor the client's weight. We're going to initiate continuous cardiac monitoring. We're going to allow the client unlimited time to eat meals. We're going to encourage the client to participate in aversion therapy. We are going to assess the client for suicidal ideation and thoughts of self-harm. So I'm going to look in the chat and see what you guys are saying in the chat here. Okay, Junie likes number 1. Junie likes number 5 as well. Monitoring the client's weight. Go ahead.
Number 1, 2, scratch number 3.
So 2 as well, and 3, you don't like it, right? So we're going to cross that out. Aversion therapy or suicidal ideations. I think suicidal ideation is
Number
always a good
5 I would
intervention.
put, and number 4 I'm not sure.
Okay. What do we understand for aversion therapy? What do you guys think of that? An aversion is something that, for example, if you don't like something, so you try to avoid it. Or you associate a behavior with something bad, for example, with alcohol or with smoking. There are certain treatments that we can offer the client that, next time they grab a cigarette, maybe they get sick if they do, or for alcohol, for example, you remember there's medications that we can give that if they drink alcohol, they get so sick that at the end they said, you know what, I'm never drinking another drop of alcohol because of the way that make me feel. It caused me an aversion. So it made me think of that as something that I don't want to ever do that again. I guess you associate that behavior with something negative. So therefore you don't want to do it. Now, how can we apply that to anorexia, right? So maybe the fact that if they don't eat, they're going to get sick, but I'm not 100% sure either. I mean, I think aversion will be more useful when you're trying to quit a substance, addiction, sometimes maybe for phobias. But
They
I
do
don't
have
know.
a negative feeling about like foods in general and stuff like that. I'm not sure if that would help, but I've never heard about aversion therapy on.
Yes, I'm not sure. So again, as a strategy, when we're not sure, we leave it alone. It's best that we put in the bag those 3 points that we 100% know, right? And we get those points rather than risking losing a point for an incorrect question. I will leave it like that, Joan. Yes, very good. You
Great
see?
job.
Great job. Great job. So yeah, because also, I mean, there's nothing that there's no, like I said, usually is when you're trying to kick a habit that you would use aversion therapy. So you will start assimilating the habit with something negative. It's not the case in anorexia, right? In anorexia, the person, they already have an aversion, and the aversion is to food. They don't want to get fat, or they see themselves as fat, even if they're not. Very good. So obviously we need to monitor the weight, not so much to tell the person, because remember, these people have an obsession a little bit with their weight, right? So obviously they gotta continue to keep losing weight and keep losing weight and keep losing weight. And like I said, even if though they look cachetic in their eyes, they think they're still already fat. So, or overweight. So we do need to monitor once they are in our care, because we've got to make sure that they are gaining weight. That's the purpose of the therapy. We need to make sure that they have enough calories to support life and to support their organs. And we need to make sure that they're gaining weight instead of losing, because if they're losing, it could be that somehow either they're vomiting or they're hiding their food or they're just not eating, right? Heart rhythm, absolutely. Remember, there are a lot of electrolyte imbalances that come with anorexia, especially hypokalemia. And any disorder in the electrolytes with potassium, whether it's low or high, the very first thing that is going to get affected is the heart. Those could be, and it's ventricular dysrhythmias usually that this leads to. Those are the deadliest ones, so we absolutely need to monitor. Obviously, other electrolytes like sodium, sodium would affect the brain a little more. So I guess a good strategy is when you think of potassium, although sodium can also affect the heart, but is more related to brain. So think sodium will affect the brain. So if they're telling me that there is an imbalance with sodium, and then in the options, there's something related to level of consciousness or mentation, that's probably a safe intervention. And when they tell you potassium, always, always, always think of the heart and dysrhythmias, especially ventricular dysrhythmias, fibrillations or tachycardias, right? Ventricular. Obviously, self-harm, suicidal ideation, because usually people who suffer from anorexia nervosa, there is also a mental health component, and we always need to assess for depression and for feelings of suicidal ideation. That is always a very important intervention with any of our clients with mental health. Great job, guys. Oh, look what it's saying, that what we need in this case is cognitive behavioral therapy, not aversion therapy. Very good.
Okay,
So
let's
what?
go to the next one.
Oh, that looks better. I don't know. I think you maximize it and it looks better. The labor and delivery nurse is caring for a client who is undergoing induction of labor for intrauterine fetal demise. Which of the following nursing actions are appropriate for supporting this client? So basically, their baby died in the womb. Discuss the desires for viewing and holding the infant, explore the client's need for spiritual support, express empathy when first meeting the client, offer photographs of the infant and other keepsakes, talk about possible reasons for the fatal death. Very important topic. So again, this person is,
Induction for labor.
They all seem pretty good to me, to be honest.
yes, I like from 1 to 4. And I'm gonna say why I don't like 5. I don't like 5 because look what happens here. So this mom is going to have to deliver a baby that is going to be born dead. If anyone, if you know someone that if you know someone who has lost a baby or had a miscarriage, there's always that feeling of, did I do something that could have caused this? Is there a behavior that I'm having? Is there something wrong with me or something wrong in my body? Number 5, when we're trying to look at possible reasons, that translates to me as to why. Why did your baby die? And the why, remember, we kind of steer away from asking why. That person, that poor mom, just think of this. She's going to have to go through the whole labor. She's going to have to get induced. She's going to have to get dilated and then deliver a baby that is going to be born dead. She's emotionally devastated. So is the father of the baby. The entire family is going to be devastated. And then if we're going to start trying to figure out why, we can also now be going to the place of, okay, maybe you're to blame. You know what I mean? So that's why I really don't like, but I like all the other ones. All the other ones I like. Just Maddie is saying we're not doctors. I don't know what you're referring to. Just Manny saying 1, 2, 3, and 4. Judith also likes 1 through 4. Just Mary, do you want to elaborate on to what? I don't know if you're talking about this question of a
So,
different.
are you able to hear me?
Yes.
So, I mean, we're not doctors in terms, I guess I understood number 5 as talk about possible reasons for the fetal death. A lot of that requires a lot of medical discussion and most likely diagnosing of medical things that a doctor should be discussing them with, not us, because at the end of the day, we're more about the supportive care. So that's what I mean by we are not doctors in terms of saying this is why your baby passed away.
I like that too. You see, this is why I love the discussion because I'm looking at through the emotional part. She's looking at through the more, uh, you know, scope of practice. Obviously, yes, we remember we don't explain diagnosis. The doctor has to explain them first, and then we reinforce the teaching of the diagnosis that the doctor say. So yes, if we're talking about possible reasons, we also could talk about a diagnosis. And diagnosis, 100%, like just Manny said, is the scope of practice of the doctor or a nurse practitioner. We, so far at this level, we're talking just nursing. Great job, guys. Beautiful.
Perfect.
So one, whatever rationale you're looking at it, obviously we're not. We're not there. So it says right here, that often we don't really know why there's fetal demise in the womb, right? Or miscarriages. A lot of the theories are related to genetic conditions, so genetic malformations. There was something that went wrong when the baby was forming. There was a genetic malformation, or there was a genetic disturbance that caused the mom or the mom's body to reject the baby and ended up in a miscarriage. One way or another one, it will be very difficult for a doctor to also diagnose what caused an intrauterine demise, right? Unless you probably take that baby to an autopsy, which probably no one would want to do. Very few people would want to go and put on a baby through an autopsy to determine exactly the cause of death, unless there's something clear, right? Maybe the baby got strangled with the cord while it was in intrauterine or in the process of being burned. But again, very, very traumatic. Now, it does say that we need to avoid speculation, guilt, because of guilt. We don't want the mom to feel guilty about that. And like I said, maybe you are not familiar with anyone who has experienced a miscarriage before, but if you have, you know that there's always, obviously, deep sadness, but there's always the feeling of, was there something I did? And why did this happen to me? Like the mom is already thinking that. So if we go that route, we probably will exacerbate, make that worse. Now, it does mention there that if the family wants an autopsy, that might be providing more information. Like in reality, the only way that we can 100% know the cause is if the family wants to perform an autopsy. But either way, very, very good job, guys. Oh, something important with that. How do you consider that? It has to be 20 weeks, before 20 weeks, right? And so, because remember for the GT PAL, we need to count, miscarriages and all of that. So less than 20 weeks. That's considered a baby who's not alive after, I'm sorry, less than 20 weeks is your miscarriage. Intrauterine demise has to be older than 20 weeks, so past 20 weeks. Before 20 weeks is a miscarriage. Anyone wants to read? Don't be shy, guys. Practice your English. Practice makes perfect. And this helps you understand questions too.
Okay, let me read. The nurse in the mental health unit is caring for a client with schizophrenia. Which of the following action by the nurse could be consistent with the orientation phase of therapeutic nurse-client relation? The phase is therapeutic nurse-client relation. And we're looking for consistent. Okay.
With orientation phase. Yes.
For the orientation phase, yes, orientation phase. Let's include this one too. We are having a client that have a schizophrenia. Okay, we have the following options: evaluate the client progress, review the client's laboratory test result, develop a plan of action for achieving goal, or discuss the client healthcare plan for future.
Okay.
I would remove 1, 3, and 4, I think. I don't think those are part of orientation. Those are working phase.
Yeah. Yeah, because remember, in orientation is, think of what we do in an orientation. Like when you guys finish your Bright Star, or you guys finish your integration and you come here for orientation. And orientation is like the first time we're meeting, we're setting up the parameters. What do we want to do, right? Obviously, evaluating will be at the end, right? We did this whole thing, and now we evaluate how we did it. Develop a plan of action for achieving goals, review the client's laboratory test results, discusses the client healthcare plans for the future. So in orientation, basically, we're building rapport, right? We want to talk about what brought you here. You and I build a rapport. Is this relationship going to work? Do I feel like I can trust this doctor? Do I feel like this is a provider that has the best of interests? And then we're going to tell them what's wrong with us. And then we're going to develop, okay, here's what we're going to do. Let's do it. Now, that in mind, Judith says she likes number 2. No, develop a plan. Yes, absolutely. Because look, on number 2, you did laboratory results, which means that you discuss what lab results you were going to do. Remember, in the first stage, we're building the plan. We're developing, we're meeting each other. You're telling me what's wrong with you. And I'm telling you, okay, here's what I want to do. Let's say your person has a rash, but they don't know where this rash comes and go. So they come to see you. And then in the first initial stage, in orientation phase, we're like, okay, doctor, I have this rash. It happens this, and that. And then I'm going to say, okay, since we really cannot pinpoint, we don't really know what is causing. We don't know if it's the stress. We don't know if it's something autoimmune. We don't know if it's an allergy. So let's go and do allergy testing. Let's go and do some blood work. Let's go and do a diet, right? We're planning. We're developing what actions we're going to do. Now, the test results are going to come after you get out of my office, and now we start working. We're starting doing something that we need to do. The things that we discussed that we're going to do, you're going to do the labs and all of that to determine what happened. Then I'm going to once we pinpoint, okay, what it is, the next step would be, okay, you do this treatment. After you do this treatment, then you're going to come back and we're going to evaluate whether the treatment worked or not, or if we have to reevaluate and go a different route. Let's see what it's telling us there. We lost the screen, Yoan.
Hold on.
It's great to see everybody here. Please make sure that you go sign your attendance in the chat. If you pin it at the top of the chat, you see Yoan has it pinned right there at the top. I have it pinned at the top of the chat as well, so you can find it there. All right. So let's see. Obviously, we got to work together in orientation phase. You're building rapport. You're creating a relationship. You're creating goals. You're going to develop a plan of action. What are we going to do to address the problem that the client is having? We're going to perform introduction, gather the information for the client, establish a trusting relationship with the client. Very important. When patients come in to any setting, this orientation is always done by the nurse. Very rarely you go to see a doctor and the first person that you encounter is the doctor. No, Most of the time, if you go to a hospital, if you go to urgent care, if you go to a clinic, if you go even for a medical appointment, who is the first person you do? The first person you see is the nurse. The nurse is the one that says, hi, welcome, come in, let's take some vitals. So what brought you in today? The very first questioner is the nurse who does it. Then she gives the little report to the doctor, and the doctor comes in with your charts and start asking you all the same questions all over again. But the orientation, that report is first, almost 100% of the time, done by a nurse. Now, evaluation, we talk about, this is the working phase, right? We're going to use whatever we got, information that we got to do further interventions if we need to. If not, then we said, okay, we resolve the issue end of this relationship. Text results, medical records that comes pre-orientation phase used to establish a strong foundation, creating client-specific interaction. Discussing the client's future health care plans occur during the termination phase. Future plans help to continue care and discharge and reinforce education provided during the working phase. So write these things because they're not that common in the Nclex, but maybe you might have a question or two about this. If I'm not mistaken, I think I got one question because, you know, my Nclex had a little bit of everything. And I think I had like a question, one question about something like this, like the different phases. So remember, there are 4 phases. You have pre-orientation, you have orientation, you have working, and then you have, that's it, right? Termination phase, termination. This is a foundations concept. If that is clear, we can move on. Who's reading? Don't be shy, guys. I want to hear your voices.
Okay. The nurse is assessing a client with obsessive-compulsive disorder. Which of the following findings would be consistent with that condition? Anxiety, defiance behavior, realistic behavior, evaluated energy levels, and persistent intrusive thoughts.
Thoughts, yeah. Okay, so
yeah.
Hold on. Someone is sending in. Where did my chat go? There. Just money, likes 1, 3, and 5. I agree. There is anxiety. There is ritualistic behavior. Fatima agrees. I don't know if Fatima or Fatima. Tiffany agrees. 1, 3, and 5. Lorenzo. Ciao, Lorenzo. Lorenzo likes it too. Yeah, remember, obsessive-compulsive disorder is definitely an anxiety disorder. This is the person that has to do the same thing or the same rituals a bunch of times. And the reason why they do it is because they have so much anxiety built up that doing these behaviors helps them with that anxiety. It helps them feel better and kind of calm that anxiety a little bit. Dr. Yoan just sent the attendance form again, guys, so don't forget to sign it. Thank you for sending it. Remember, you see those 3 little dots on the right? If you click on that and click on pinned, you can pin that on the top of your chat. So every time you come to this meeting, it's easier for you to find that link. Thank you so much, Yoan. All right, so going back to the question, we were saying 1, 3, and 5. I like that. There's not defiant behavior. Defiant behavior will come from someone who has either antisocial personality disorder or someone who has, yeah, well, the antisocial is the one that has that defiant personality disorder, which later on in life, this is the name they use when the person is younger. Later in life, they just are diagnosed with antisocial personality disorder and elevated energy levels. That's either a person who's on mania or hyperactivity or disorder, right? So I agree. I like 1, 3, and 5 as well, Joan. Great job. We can send, Joan, if you put in that image, I can take a screenshot and send it for them to have.
Okay, I will.
Oh, let me see how to. Let me see. How can I do the screenshot? Let me see.
You can use this one. The spinning tool. With the spinning tool, you can do this one quickly.
Okay.
And even you can print out. It's
Oh, I
called
love that.
yeah, it's called a spinning tool.
I like that. Yeah, because you see, look at what the picture's saying. Like I said, I love pictures because pictures will help you create memory.
Yeah.
And pictures, maybe you don't remember a bunch of letters, but you might remember um an image. So as you can see, he's saying, oh my God, these germs are going to make me deadly ill. So this is the person, when we call a person who's a germophobic, that is a characteristic of someone with OCDs. They joke a little bit in the ICU, that ICU nurses have OCD. And yes, we're a little OCD with the way we want our lines to run and the way we want our rooms to be. And I know several nurses in the ICU that for sure have OCD and they have to roll the gown a certain way when they take out the PPE, and they do all these rituals with their rooms that you're like, this one's OCD for sure. Wash my hands. Look, what this is all in their head, right? So that's also very important. Their head is going the whole time. They don't get a break. It's massive. This produces massive anxiety, all these thoughts that they have. That's what it called the intrusive thoughts. They think I must wash my hands scalding water for 5 minutes to avoid getting sick. So again, this person has a fear of getting sick. So they do all these things continuously because they think they're getting sick. Um, this person, for example, he's thinking about someone's going to harm their child. I must count these hangers to keep my child safe. Even though it seems like it makes no sense. Like, how does counting hangers um help you keep your child safe? But in their mind, it makes sense. Sometimes, like I say, we all have a little trace of something. Some people is the person that will leave the house, and before they leave the house, they have to check every single doorknob, make sure that the doors are locked, or they have to check the stove, and they go out and they check it and they go out and then they come back because they have to check again, and then they go out and they get in the car and I'm like, oh my God, did I turn off the stove? And they come back. Or they have to touch a door 3 times before they go in. I've seen clients when I was doing rotations. We have this one client that she would literally open the door, go out, come back in, go out, come back in, like 15 times before she can actually feel calm enough to just go out and walk out that room. Uh, when it comes to intervention, we allow them to have this these behaviors, these ritualistic behaviors, because like I say, that helps them with that anxiety. It helps them feel better. It helps calm them down. Obviously, with cognitive therapy, the goal is that they don't need to do these behaviors as often, right? We want to start cutting down, but we do need to allow them to have the behaviors. Let's see what they're doing. Yes, defiance, like I said, oppositional defiant disorder or ODD, which usually this is, like I said, this is the name they use when the person is younger. As they become adults later in life, they probably get diagnosed with antisocial personality disorder. Your antisocial personality disorder is the person who has no regards for law, who will get in trouble with the law because they don't think they have to follow the law, and they have no regard. They don't feel bad that they hurt you. They don't feel bad that they broke the law. Remember that this comes with low self-esteem. In the case of this person, no, there's not really so much a self-esteem of OCD. It's more about just anxiety and trying to regulate the anxiety. Let's see what else we have there. Yeah, mania, when it comes to a person who has high or elevated levels of energy, or again, a hyperactive disorder, an ADD or ADHD. And specifically ADHD, not so much on ADD, because an ADD is more of attention deficit hyperactive disorder. That's when you see the client who cannot focus and they seem to be jumping from place to place, from place to place. Very good, guys. Next. I don't know if there's any questions or comments. Please open up your mics. Give us your thoughts too.
The nurse is caring for a client who practices coping, and the nurse should understand that coping is used to 1. Improve balance, 2. Stimulate blood flow, 3. Block the transmission of pain, and 4. Regulate the flow of energy in the body. I think it's number 2.
Great job. Just Manny agrees. I agree too. Remember, copying is that technique in which it's an oriental technique, I say, is very, very popular now, especially if you're into holistic treatments. It's when they put those, it's like a glass cup, and basically they apply suction, and they are placed, especially in the back. They can place it in different parts of your body, but typically in the back, and they leave these marks. Remember also when we are assessing for abuse, and if we have a client that we're doing assessment and we see this pattern and it's a very defined circle, and we see it in a pattern that maybe goes down the back, obviously we're not going to suspect abuse. We suspect that this person follows or is doing copying or is doing holistic treatment as well. So, and yes, it does help stimulate blood flow. That, in reality, sometimes it could be led if the person has an area where they have pain or soreness. The belief or the rationale is that by improving blood flow or by stimulating blood flow into that area is going to help eliminate or improve that pain. Not necessarily blocking the transmission of the pain, but just minimize it. Blood flow can stimulate that area to help provide relief. But the rationale is, yes, blood flow. Great job, guys. There it is. As you can see, they use these little cups that create suction on that specific point. And as you can see, it does leave a very defined mark in the body. And this sometimes, certain cultures use this in young children, right? So don't be surprised if it's a teenager or a young kid who actually has this. It's not just specifically for adults. And it's not abuse. We're not going to call anyone and say, oh, they're abusing this child. Remember, this is a belief, a part of a cultural belief. Whether we agree or not, again, that's our personal bias. If you want, let's see if you can put in the acupuncture so they can see. I mean, we all kind of know what acupuncture is, but you could probably see a picture there. Like I said, I love pictures. Let's see what else. Yeah, obviously this is part of culturally competent care. Remember, yes, we that's the job of nursing is that we provide patient-centered, culturally competent care. We provide care to everyone, regardless of race, culture, gender, political affiliation. We provide care to anyone and everyone. We got a little scenario. Fatima, you want to read or someone else?
Yes. Okay. Which of the following actions by the nurse would require follow-up? 1. Tells the client to schedule regular visits with a healthcare provider. 2. Request an order for a repeat pancreatic biopsy. 3. Ask the healthcare provider for a prescription for a selective serotonin reuptake inhibitor. And 4. Screens the client to substance use for
Oh, we
substance
need,
misuse. Sorry.
yes. Now read the scenario, right? We got to read what the question is having.
Okay. Nurse's notes. Reports anxiety and increased stress. States, I just know I have pancreatic cancer, but no one can find it. My previous healthcare provider couldn't find a tumor either, but I know that I have one. Testing for pancreatic cancer 8 months ago was negative. Reports no abdominal pain, nausea, fatigue, or weight loss. Abdomen soft and non-tender. Laboratory test results with normal limits. CT scan of the abdomen, negative for abdominal mass. Pancreatic biopsy, negative.
Very good. So what is inappropriate to tell this client? Clearly, this client has nothing medical that we can explain medically, but they do have
Number
a
2.
mental health condition. Very good. Yes, Wanda likes Josmani, Marlene, they all like number 2. I like that too. We're not going to repeat a biopsy. That is an invasive procedure that the person already did. And it was negative. And all the scans, they have had CT scans, they have everything done that we can do medically, and they clearly don't have a tumor. What they have is a mental health conditions. They have what is called illness, anxiety disorder. We commonly tell them they're hypochondriac, right? They're making themselves, or they read something and they think they have it, and they think they have every disease, and then they go on Google, and every symptom they read, they're like, oh my God, I have this. And in reality, this is another one of those anxiety related disorders. So obviously, what are good interventions? Anything that helps us prevent anxiety or minimize anxiety, because we all have a little bit of anxiety, especially these new generations are coming with a lot of anxiety, or fast-paced social media, all these expectations that, again, due to social media, that when kid is comparing themselves to the other one, they see someone's perfect life and they think they need to keep up. School, we're also having this very, very high expectation for school-age kids. That brings a lot of anxiety in children. And now we're seeing more and more very young kids dealing with massive loads of anxiety. So I'm not surprised that the NCLEX will probably want to start, because remember, the NCLEX is definitely going to ask you about things that are happening in the world right now, because we need to care for those patients. So I'm not surprised if they start asking about this, because young patients have massive, and doctors are diagnosing anxiety in kids 10, 8, 7 years old. So those patients are going to come and we're going to see them. Obviously, if there's no interventions early, this is only going to get progressive, and that can bring chronic health issues. Again, this is anxiety about having serious undiagnosed illness. Even if you tell them that everything is negative, this person is going to continue to feel that they have that they're that they are sick. Something different, something important here is that they don't have somatic symptoms, meaning they don't really have a symptom. They're not telling you they're feeling fatigue, they don't have nausea, they don't have pain. But again, they believe that they have this. Obviously, the very first thing we do is rule out everything medical. If it's nothing medical, then we go back to say, okay, what's causing your issue is anxiety. We need to start giving you tools to work on your anxiety. Obviously, number one is okay. We definitely want regular visits to the provider, because what this kind of helps a little bit to reassure the patient, right? Okay, so come every 6 months to see the doctor, just to get, routine labs and make sure that everything is okay, that your lab work is within normal limits, that you are okay. And don't be surprised, this client could probably be visiting the emergency room, once a month or more often, if because they feel that they're sick from something. SSRIs, yes, SSRIs are good in helping the anxiety in those patients. So an SSRI or an this is an SNRI, right? Yeah. Oh no, an SSRI. SSRIs and SNRIs are pretty much the same. They kind of have is I don't really learn them separately, because they pretty much have the very same interventions, the very same possible side effects. So you can kind of study them together. Remember, the treatment of anxiety requires not only medication, this requires cognitive therapy as well. We need to teach the person coping strategies, breathing exercises, yoga, whatever you can to help this patient manage their anxiety. let's see, a screening for prescription or recreational substance misuse. This will be appropriate for a client who has IAD because substance use can worsen IAD and increase the risk for complications. Absolutely. Also, this is a patient who maybe they feel they're getting sick with something, so they might be taking things over the counter just because they read it or they saw somewhere that that helps, even though they don't have that condition. Very good. Next, and this falls into that umbrella of somatic disorders. So I don't know if you remember that there's an umbrella when we were studying mental health. These are the somatic disorders. Who's reading?
I'll read. The nurse on the mental health unit is assessing clients who have the potential for violence against others. Sorry. The nurse should recognize that the clients at highest risk for impending violence is the clients who, and the options are: ask loudly, how do you expect us to get better when you cancel recreation therapy? Maintain intense direct eye contact with the therapist during group therapy. Move from chair to chair in the common room while swearing at the television announcer, and states, "This is embarrassing. I always cry when something makes me angry."
Okay, you all guys, you all like number 3. Who is more likely to attack you? Who's ready to come and give it to you? Asking loudly, how do you expect us
Loud.
to get better when you cancel recreation therapy? So this person is escalating, but it's not impending. The word impending means any second they're going to jump and attack you. So again, semantics matter. Impending means like when a person's having, when we're saying that someone's having myocardial infarction and they have impending doom, they feel, oh my God, I'm dying. And I kid you not, guys, when a patient tells me, oh my God, me estoy muriendo, I'm dying, guys, I think I'm dying, you run because they're dying within seconds. So that just to tell you, impending means coming. Any second they're gonna come and attack you. Intense direct contact with the therapist during group therapy. This is escalating, right? So this person now, I don't know if it's impending, but this is escalating. They're looking at you intensely. Maybe they're gonna clench their fist. Maybe they're clenching their jaw, which also signals of possible aggression coming. So that could be. But now number 3, they're moving from chair to chair in the common room and they're swearing at the television. So they're already agitated. They're already screaming F you, Nana, at the TV. Any moment they can grab a chair and just throw it at you. Number 4, obviously, no. She's saying no, she's embarrassed because she cries when she's angry. So something makes her, she's angry at something, and instead of attacking someone, she's crying. So I think I will for sure rule out 1 and 4. That leaves us with 2 and 3. And the group seems to be divided. No, wait. Never mind. You guys unanimously like number 3, Lorenzo, Fatima, just Mari. You think number 3 is already acting. Because number 2, yes, it seems like he's looking at you like he wants to. But number 3 is actually doing something. They're already like pacing, right? Moving from chair to chair is kind of pacing, right? Very good. So they already escalating. The next client that's going to attack you is number 2, because he's already escalating. So that's the client that you need to keep an eye on. You need to either remove everybody from that room or probably not remove that patient, remove everybody else to keep them safe and have someone come and help you because, okay, that person is escalating. Very good. So what I was telling you, how do we know someone's going to attack you? You have physical cues. Like I said, they're clenching their jaw and they have their eye on you. And if you look at their hands, they probably have their hands like this. They're ready to punch. They're ready to throw down. They're tense. They're rigid. Hyperactivity again, from side to side. They're pacing. They're speaking loudly. They are cursing. Obviously, that's a clear sign of agitation, and that can turn into a physical fight at any point. And verbal abuse, arguing, profanity, and threatening language. Very good. That is escalating behavior, like I said. quickly we need de-escalation technique. If de-escalation doesn't work, that's when you come for help. You need to give a shot. Medication. Very good. Wants to read?
The nurse is in outpatient clinic, is teaching a parent of 8 years old client with deficit hyperactive disorders. The outpatient clinic. The parents reports client have poor school performance, difficulty making friends, and increased the energy levels over the past 8 months. Parents receive frequently phone calls from the teacher who report client has difficulty staying in a seat and does not listen in class, forget to complete the daily chores at home, regularly lose homework assignment, metrylamine prescribed,
Methylphenidate.
methylphenidate prescribed. Um, Jose Rodriguez was here waiting.
I just
Okay.
let him in.
Okay, perfect. For which of the following statement by the client's parents, click specifically whether the statement indicate understanding or non-understanding of the teaching provided. I will offer my child smart and frequently meals. I should limit breaks between my child's activities. I will consume frequently with my child's teachers. I plan to administer methamphetamine to my children. Say it again?
Methylphenidate.
Methylphenidate. I plan to administer methylphenidate to my child 2 to 3 hours before meals. I should minimize distraction while my children complete household chores.
All right, so what is appropriate? Offering small, frequent meals. Think of this, the hyperactive person, the person that cannot sit down. They have a lot of energy, so much energy that they really don't have time to eat. They have no time to sit with you, right? So I like them. I'm not mad at that. Small, frequent meals, because maybe they don't want to sit for a large meal. Limit breaks. I think the opposite, right? We probably need to give them break because again, think of this, especially when it comes to academic work. This is a child that is going to sit and they're going to look at something and they're going to try to concentrate and their mind is somewhere else. Their mind is listening at the bus passing by, looking at the flickering light, watching at the teachers, I don't know, mole in their forehead. So it's very important to give them breaks. And I think sometimes it's unlimited breaks. It's, do something, okay, answer this question, okay, get up and take a break. You can do tools like this so they can fidget. Instead of having them sit in a chair that's constricted, get them on a ball. So while the client is doing the homework, they can be doing this. Very good. So Fatima likes understanding number 3, communicate frequently with the child's teachers. Absolutely. Because imagine being this teacher and you're trying to give class and you have this kid doing all these behaviors that obviously are going to be disruptive for others. Unfortunately, teachers cannot have the luxury of teach just to one person. They probably have 20, 25 kids in a class. They need to teach to everybody. So obviously we need to have open communication so the teacher knows what strategies to use and how to manage your child. That's a good intervention. Methylphenidate. Are we going to give methylphenidate 2 to 3 hours before meals? What do we know about methylphenidate? It's a stimulant medication. What do you guys know? If you don't, go ahead.
This medication causes insomnia, right?
Yeah, it's a stimulant. So, obviously, remember the important thing with
Suppress
stimulants.
appetite.
Yes, it suppresses the appetite. So there's certain like very important things, even if you don't remember everything. But if you're stimulating, which it kind of sounds like, wow, but this person's hyperactive. How am I gonna? It seems counterproductive, but stimulants, yeah, like I say, they suppress the appetite. So anorexia is one of those things. And literally it's because they don't feel hunger, or thirst. So we have to remind them to eat and to drink and to keep hydrated. It will give them insomnia. So if you usually give this early in the morning, if the patient requires 2 dosages, you should not give the second dose too late in the afternoon. Now, 2-3 hours before meals, I guess the rationale here would be so the patient can actually still maintain the appetite or not. I don't know if two,
I
three
think
hours
it should be
before.
after.
It should be after meals, right? I agree. So maybe not understanding. I should minimize distractions while my child completes household. Absolutely. Household chores. Absolutely. Minimize as much as you can. Try to maintain a routine. Give them a space that doesn't have a lot of distractions when they're doing studying. This is one of the ideas or the concept, for example, of testing centers and why you have, and this is how you test that way in the Nclex. They give you a cubicle and there's not much in the walls because they don't want you getting distracted. They want you to kind of just center in and focus on your little cubicle. So I think that's a good intervention, trying to minimize distractions. Let's see what else you guys are saying. Let me see. Just money saying, isn't it before bed? To give the medication before bed, you mean?
Sorry, I think I confused it for another ADHD medication, which I think is supposed to be given before bed. I don't remember
Okay,
the name, but it was another one.
okay, okay. Let's see what else you guys are saying. Okay, let's think about. Oh, we did it correctly. Perfect. Yes. I think the methylphenidate should be given before meals, but let's think about, remember when we talk about peaks and troughs and half-life and all of that? We should give it before it start making effect so the client can actually eat before it makes them not hungry. So I'll say 30 to 45 minutes before the meal. So the client takes it. This is still, the medication has not reached that peak of action. So they will still feel like they can eat half an hour later. And because in about an hour or two, when the medication is at peak, they're not going to eat. So very important. So when it comes to timing, think of that. How much, usually oral medications takes between 30 to an hour for them to be effective. So, and peaks and troughs, they vary, but we do think more or less that if we want a client to be able to eat, we don't want to wait until the medication is at its peak effect, because then it's making the more effect, and that's when the patient is not going to feel any hunger at all. You can scroll and move on if you want, Joanne, I don't know. If there's something important there that we need to read, let's see. Small frequent meals, like I said. Number one, because of the hyperactivity, they're not going to feel hungry. And if they're taking medication, even less. And this is one of those side effects, remember, important with ADHD, usually given to school-age children. And remember how important it is for school-age children to have proper nutrition because they are literally actively growing. So they need to have proper nutrients. This is the amount that we're going to recommend supplementing with one of those drinks, a Pediasure that has a lot of calories. It's just a small little bottle. And the child, if they didn't eat well, at least they're having some extra calories and extra nutrients from one of those drinks. We talk about why it's important to communicate. We talk about what is minimizing distractions and limiting breaks. Again, no, we need to provide them with those breaks. And there's a lot of also behavioral therapy here. Okay, let's do this. Let's break down the homework. Because if you give them a whole page of homework, they're going to be, oh my God, it's 10 questions. And they're going to be overwhelmed before they even start. Let's break it into small pieces. Okay, do 2 questions, and after you answer 2 questions, then we give them 2 minutes to get up and to steam, to get up and to jump, to get up and to bounce in the, whatever it is, little breaks, as many breaks as they need so they don't become overwhelmed. Very, very, very good. And it says, yeah, we should take the methylphenidate with or after the meals to minimize the side effects. So I would say a good
With or after, right?
with or after. So I would say if you do it, half an hour is okay. After, okay. So have the child eat and then give them the medication so it doesn't suppress it. But I think within 30 minutes we're okay because medications usually take 30 to an hour to start working.
Okay.
Very good.
Okay, let's go to the next one.
We have a 2-day-old client. Who's reading this one? I'm gonna read it then. In the postpartum unit, there's a 2-day-old client, appears irritable, difficulty with feeding, increased muscle tone, and hyperactive reflexes. The palpebral fissures are short, and the philtrum is smooth. There is a maternal history that includes consistent alcohol use throughout the first and second trimester, with last alcohol use that was 3 months ago. For each potential intervention, click to specify whether this is appropriate or inappropriate for the care of this client. We're going to monitor the intake and output. We're going to decrease environmental stimuli, provide the client with small, frequent feedings, assess the client's ability to suck and swallow, instruct the parents to discontinue breastfeeding. Obviously, it seems like this baby is probably in an alcohol withdrawal. It's the child of an alcoholic mother. Now they're probably going through withdrawal. So intakes and outputs, I think that's an appropriate intervention, right? Because if we have a 2-day-old baby, we want to make sure that they're properly hydrated. We definitely don't want them dehydrated. We want to know how much they're taking in, how much they're excreting. So I think that's appropriate. You guys agree? Even if we don't know much about, alcohol withdrawal, trying to see if this baby is properly hydrated, I think is okay. Decreasing the environmental stimuli. Yes, again, with any alcohol withdrawal, remember, there's a risk of seizures when the substance is not, remember, the baby is being born addicted to alcohol that he was receiving through the umbilical cord. Now he doesn't have that, so he's going to be experiencing withdrawal. And with withdrawal comes delirium tremens and seizures. So it is important to decrease the environmental stimuli to prevent seizures. Provide the client with small, frequent feedings. I like that because, again, energy, it helps with energy conservation. We don't want to overtire them. They're already having difficulty feeding. So that's a good intervention. We don't want to get them overtired. So the first 3, Yoan, are appropriate. I think we're discussing that. Let me see. Fatima likes from 1 to 4. Wanda as well. Jordan likes 1, 2, and 4. Assess the client's ability to suck and swallow. Yes, I mean, we gotta, like I said, we always rule out things first. Why is this baby having difficulty feeding? Let's see, can they suck? Can they swallow? Is that impaired? Is there something physical that might be impairing that? So I think assessing that is okay. And number 5, discontinue breastfeeding.
No.
I don't know. Now,
No, I don't know.
remember when moms drink, if you are breastfeeding, you can do what is pump and dump, meaning that, you're a mom, you're breastfeeding, but you've been without alcohol for 9 months. You want to have a girls' night. You go out and you drink a little, 1 too many glasses of wine. You can still breastfeed. It doesn't mean you're going to stop breastfeeding. I see discontinue, meaning don't give any more breast milk to the baby. No. Hopefully, you can pump and dump that milk. But then by the next feeding, I'm sure the alcohol is probably out of the mom's system so she can safely feed their baby. I like that photo too because those are common features that you would see in children who are born with FAS, fetal alcohol syndrome. They have a small brain or microcephaly. They have small palpebral fissures. As you can see, it's like the people that, some people that you will notice that they have, the fissures of the eyes are like kind of fused. I don't know. They almost look, I don't know how to describe it, stretched maybe. Mid-face hypoplasia. So yes, this is like flat over here. They have a small philtrum right here on the lip. They have like a very small upper lip. The thin vermilion border. So you see the philtrum is, you see how, I don't know if it's very noticeable on me, but we all have, you see this little line that forms at the bottom of your lip? They don't have it. Sometimes their eyes are also like wide apart. They have like a wider space right here between their nose. There is like a famous actress, I think, that has this. I don't remember the name, but there is a famous actress that has this. Let's see what else. Obviously, you can have physical, developmental, cognitive abnormalities. Again, pregnancy complications, can be stillbirth, can be miscarriage, can be preterm labor. Obviously, when the baby is born, they have, like I said, alcohol withdrawal. So they're going to have all the signs and symptoms of alcohol withdrawal. They can be diagnosed with failure to thrive precisely for what they're describing there. It's a child who's going to have a hard time being consoled. They're going to have a hard time feeding. They're going to have a hard time gaining weight. And obviously, all the crying, that's going to actually make them lose calorie and lose weight. Often these clients has a weak sucking reflex. Weak sucking reflex, so with that comes that they're not going to effectively be able to eat. They're going to get tired more easily, which is why we want to not to get them too exhausted. We're going to, similar to preemies. Preemies are the clients as well that if they don't, they get tired very easily. So you don't want to be feeding a preemie baby for 15 or more minutes, because then instead of gaining weight, they're going to lose it because of all the calories they burn from the effort of breastfeeding or bottle feeding. So not too long feeds. Whatever they eat, it's better to feed them just for 10 minutes, give them a break, and then feed them an hour and a half later. Very good. So again, yes, we don't need to discontinue breastfeeding. We're going to teach the mom. Number one, she needs alcohol, alcohol cessation program. The best thing for that mom is to get into a rehabilitation program and stop drinking alcohol. Now, if the problem is, because a lot of babies struggle and a lot of moms struggle with latching, so bring in a lactation consultant. Tell them what is the proper way to feed the baby. How can they stimulate latching and proper latching on the baby? How can they stimulate the baby to suck? And basically educating them on the correct way of breastfeeding. Very good, guys. Great job. Next. Nurse caring for a client who is experiencing a panic attack. Which of the following actions should the nurse take? Let's select all that apply. Remain in the room with the client. Keyword there, panic attack, meaning it's happening right now. Instruct the client to take slow, deep breaths. Teach the client new techniques to manage anxiety. Keyword new. Speak in a calm, soothing voice using simple statements. And encourage the client to identify events that precipitated the attack. Jordan likes 1, 2, 3, 1 to 4. Fatima likes 1, 2, 3, 4. Wanda likes 1 to 4. Fatima likes 1 to 4. So I guess, I'm sorry, that was for the old one. Never mind. 1 to 4 overall for everybody. 1, 2, and 4. Liliana agrees. No, number 3, Joan. Because remember, not new techniques. They're right now, the client is in panic mode. This is not the moment to teach anything right now. Nothing new. They're actively panicking. Absolutely. Meaning nothing new right now. Not the time to let's try to identify what caused this. No, this comes after the client comes down. Right now, they're in the moment of crisis. So if you work in mental health, this is, remember, when you have an unstable client, you don't leave them, you stay in the room with them. I agree with you guys. Those 3 seems like the safest, best options. We're matching.
I'm going to take you with me.
Sorry, guys. I'm back. All right. Very good. Any questions here? Anyone else wants to add something? Let's see if there's something there that we haven't discussed. Um, Clients often feel hopeless in controlling these episodes. They can become depressed and preoccupied with the next episode. When caring for a client, then we discuss those three things. Remember, these are brief attacks, right? Anywhere from 10 to 30 minutes. There are things that we can teach them how to do. You can have them sit down. You can have them put their head between their legs and breathe. Remember, you can have them breathing in the bag or in their hands, because this client is going to have they're going to have tachypnea. And with tachypnea also comes, they're going to become alkalotic. We need them to retain a little CO2 because they're excreting all the acidity. They can become alkalotic. So that's the whole rationale of the bag. Or breathing between their legs. There's certain techniques that we can teach them to help this. Remember, this happens suddenly. This feels very much to them like a heart attack. So they can present to you with, and I have had this happening in the ICU quite often, out of the blue, or not really out of the, yeah, it's kind of sudden, but you can see it intensifying. You can see little clues. A client is in the ICU, it's usually dark, it's loud, it's busy, it's chaotic. And the person will come and tell you, I cannot breathe. My chest is hurting. I have tingling. Oh my God, I think I'm having a heart attack. And it starts to escalate. Obviously, if you're in an acute setting, first thing we do, let's rule out the heart attack. EKG takes 5 minutes. No, it's not a heart attack. It's a panic attack. And clients get often very surprised because they say, I have never in my life had a panic attack. This came out of nowhere. I've never felt this before. And it can come right for being on that setting, right? They're very helpless because the ICU and the hospital in itself is very helpless. Um, they're dealing with a condition, a physical condition, and then the environment, right? You're in a high stressful environment, and all of a sudden, oh my God, this comes. People who have anxiety, usually they're accumulating. When the panic attack happens, it's like the body's or the central nervous system saying, I can't take this anymore, and it just blows up. So very important, like I said, this feels a lot like they're having a heart attack. They feel that impending doom that you feel in a myocardial infarction. They feel chest pain. They feel a hard time breathing. So, like I say, medically, if they put you a scenario about this, we first rule out medical causes. So if ruling out medical causes is in your options on a selective that apply, yes, we have to, even if you know for sure that this is being caused by anxiety, because they might tell you, they already perform an EKG and that the EKG shows no ST elevations. They could be in STEMIs, what is called an NSTEMI, non-ST elevation myocardial infarction. But if usually in the scenario, the Nclex will tell you or will rule that out. But first we need to rule that out because the symptoms are very similar. And then if it's not, then we go to the therapeutic interventions for a panic attack. Great job, guys. Who's reading this one?
The nurse is caring for a client who is experiencing opioid withdrawal. The nurse should expect that the client will be prescribed.
Are we going to give this client fluoxetine, methadone, Haldor, or metiperidone?
Peridol,
This was very easy. So guys, tell me, who do we prescribe fluoxetine to?
toxicity. Yeah.
One by one. Fluoxetine, who is bonus points if you tell me was, I guess, the group. What kind of medication is a fluoxetine? SSRI. Very good, just Mary. So who do we prescribe SSRIs to? And now SSRIs are coming, treating so many other things. They're good for premenstrual disorder, right? For PMS, the mom, the women, the females that suffer from premenstrual syndrome, it works fantastic for that. It works fantastic for depressive disorders, right? Very good. SSRIs. You guys say it is methadone. That's why we have those in California, not here. I don't think in Florida we have too many of these, but there's methadone clinics in which, you know, people who are addicted to opioids, they go to the methadone clinic and they get the methadone to help them deal with the opioid disorder that they have, right? To kind of quit the opioid. And there are clinics in which they actually come in and they get the methadone to help them with that dependence. Yoan, go back because I want to ask about the other ones. Because this was way too easy for you guys. So Haldol, who do we give Haldol to? Or haloperidol is your Haldol.
Schizophrenic clients.
Very good. Or if a client who is reporting a little bit of aggression, right? Agitation, they're becoming agitated and aggressive and angry and start punching and hitting. Very carefully given to elderly, right? Because remember, we can have patients who are elderly clients. We got to be very careful with this. This medication causes widening of the QRS. And the problem with widening the QRS is that the client can go into a ventricular dysrhythmia. So that's why obviously extreme caution for patients who are elder or who already have issues, cardiac issues. And methylphenidate, we talked about it not too long ago, right? Who remembers? We just talked about methylphenidate being given to. Yeah, Gabriela saying for a schizophrenic client, yes. Acute aggression or agitation, very good. And methylphenidate, we just talked about it for a client who had the little boy that cannot concentrate, cannot sit in one place. ADHD, very good. It's a stimulant. Great job, guys. Easy. Okay, who's reading this one?
The nurse is talking with the spouse of the client with severe Alzheimer's disease. The spouse state, I'm so exhausted. I have full-time job and I'm going to lose if I keep missing work. I cannot safely leave my spouse alone. Which of the following actions should the nurse take? Apply, select or not apply. Report the spouse to adult protective service. Encourage involvement in caregiving support group. Provide information about community adult daycare program. Suggest asking friends or family to assistance in caring for the client. Discuss the possible of transition the client to a long-term care facility.
Very good. So Pierre Jerry, I hope I'm saying that correctly. Pierre Jerry likes 2, 3, and 5. I like that. We're definitely not going to report this client, right? I mean, they're exhausted. They have caregivers trained. They have they're in this very difficult position. They're trying the best that they can, but obviously people need to work. This is a very real scenario. So not number 4, we cannot assume that they have family. I like that. We cannot assume that the family are going to take on that task either, right? It's clearly a massive task. I like that. Gwendolyn agrees. She likes just Maria likes number 2, 3, and 5 as well. Great job. So, okay, it says that yes, we suggest friends and family.
And
Okay,
the family
but
too. Yeah.
let's see. It's not a bad idea to be safe. So if this is in the NCLEX and you scored 3 out of 4, that's perfectly fine because 3 out of 4 is fantastic. If you're not sure, don't mark it. But I like the rationale. Yes, we're assuming that they have friends and family. But yes, in real life, we do ask, when we see that there's a person, we recently had a patient like this that had to be in the ICU for a very long time. And they had a caregiver, a wife, who she herself had a bunch of health issues. And you can tell she was exhausted, and you can tell the patient was frustrated and was getting frustrated at her. And you can see was already taking a toll on that spouse. And one of the very first approaches is there someone else that can come and help you? Is there someone else that can come and watch and be with this? Even though in reality, the client didn't really need someone there with them because they are in the ICU and we're there. But I guess because of emotional support or for the patient to feel more comfortable. But one of the first things we do is ask, is there someone else that can come and relieve you for a few hours so you can go and clear your head, so you can get out of this very confined space that in reality you don't need to be because you're not the patient. And that is one of the first things we assess. Can someone else come so you can take a break? So it's not bad to say, can you ask a family member to help you, even if it's just for a couple of hours, because sometimes that's all they need, a couple of hours to go to do something for themselves, to just grab a coffee for, go to the mall, have a meal that they can actually sit and enjoy on their own. But good. Even if you're not sure, now we know that yes, it's okay to explore that possibility if there's family or there are friends. A lot of the times there are, but people don't want to ask. They don't want to feel like they're inconveniencing someone else. Some people have a hard time asking for help. But it's okay to tell them, listen, especially because you see, as a nurse, you would see that if there's a patient and you see that there's a lot of people coming to visit, that means that person definitely have a lot of other people that worried. So it's okay to tell the person, hey, it's okay. Clearly, there's people around that care for this client. Why don't you ask them for help? It's okay to ask for help. We know that the difficult thing about Alzheimer's is that this is progressive. This is not going to get better. Quite the opposite. It's only going to get worse and worse and worse. And this patient is going to eventually require full-time help with everything. So it is also not a bad idea to start discussing long-term care and more to cover more and more of the needs that the client is going to have, because eventually they're going to be 100% dependent on someone else. It's not fair, and it's definitely kind of not humanly possible to, or is to put all this responsibility in just one person. So definitely they need, the responsibilities need to be divided into people. There are programs, there are daycares, there are caregivers that can come to the home that usually are covered by insurance. If the person doesn't have insurance, again, there's also resources that can be provided for people like that. That's, I guess, one of the benefits of, our taxes. We pay our taxes, so programs like this exist so we can take care of the people who cannot care for themselves. Very good. And obviously, very important that we need to provide support not only for the patient, but for the caregiver. And we need to assess for that caregiver. Because again, with this exhaustion comes with the caregiver strain that can lead to abuse as well. So the person is so frustrated and so tired of doing this over and over that they can, if it's an elderly patient, they can either neglect this patient or abuse this person because they are exhausted. Very good, guys. Who's reading?
The nurse in the emergency department is observing a staff member caring for a client with left mandibular fractures. The client medical record have a history of intimate peer violence. The nurse intervene if the staff member is observed. Inspect the client left master area for bruising, including the client exposed during data collection. Document the client injuries in a body map or maintain the client in APO status.
Very good. Thank you, guys. I love the participation. It looks like unanimously all of you agree that we should not include the spouse in here,
Yeah,
right?
because the previous medical record.
If this person is abusing them and beating
Yeah.
them, we're not going to bring them in the room while we're trying to collect information from them. Very good. And look at this. This is important, right? Because we might be right or wrong, but every time you suspect, you will develop that little sense, that little red flag that you look and you can read a person's body language and see the physical manifestations and say, this person looks like it's being abused by someone. So how do we know? Where are the injuries? Remember, it's also with children. It's very common that kids are going to have bruises on and around the knees, on and around the elbows, because they're going to fall. The big, bruise on their foreheads because they fall or they hit their heads in the corners. What's not a common bruise? In the abdomen. Like rarely, how do you hit yourself in the abdomen, right? In the genitals, in the face, unless you kind of fall face forward. But, if you find a bruise in one eye, a bruise in one cheek, in the neck, very rarely, how are you going to fall that you hit your neck, right? It could happen, yes. Accidents and random accidents happen, but the location of the bruises is important. And usually abusers will hit someone in a place where they know that can be covered. So the torso, the back, the thighs, right? Where the person can put on long pants and it can be covered. An inconsistent explanation, evasive or fearful when we're interrogating. Non-adherence to follow-up emergency department visits. A partner who resists patient being seen alone. Discomfort in examination. Sexually transmitted infections. Chronic pelvic pain. Now, what are the strategies that we use? If we're suspecting that, make sure that we interrogate this client in private. Non-judgmental, empathic, open-ended questions. Open-ended, very important. Do not suggest, do not give cues. Ask questions that will require the person to give you an explanation. Avoid pressuring to discuss abuse or report or leave the partner, assess immediate safety, determine emergency safety plan, provide referrals for resources as needed, like shelters, domestic violence agency, and mental health. Safety plan is super important. What do you do in the case that your life is in immediate danger? If they can, obviously, they should just get out and leave. But it's important that they know what to do. Who do you call? Where do you go? Have a bag ready, hidden someone with the essentials, some cash, your important documents, some clothing. Have telephone numbers of people that you can call and they can come pick you up. And it is safe in the event that you have to leave in the middle of the night because there's an emergency, okay? Great job, guys.
Good job.
Who else is reading? Should I read? Okay, I'll read. Nurse in the emergency department, caring for a 2-year-old client, 22-year-old. This is the ER. The client arrived at the facility reporting dizziness, shortness of breath, and heart palpitations. Trembles, grips the bed rail tightly, and states, "I feel so trapped. I cannot stop thinking about my partner leaving me. My anxiety is impossible to manage." For each potential intervention, click to specify whether this intervention is appropriate or not appropriate for the care of the client. Number 1, remain in the room with the client. Number 2, use short sentences when talking with the client. Number 3, encourage the client to take slow, controlled breaths. Number 4, assist the client to identify the trigger of the current symptoms. And number 5, teach the client how to use positive self-talk to control their symptoms. Again, based on those manifestations, we already discussed this, what's appropriate, what's not. Number 1, appropriate or not? Let's see. Liliana says 1, 2, and 3. 1, 2, and 3, what, Liliana? Appropriate or not appropriate?
Appropriate.
Very good, thank you. And just Mary agrees. 1, 2, and 3. Marlene agrees. 1, 2, and 3 are appropriate. So that means that 4 and 5 are not appropriate.
Assisting and
So,
the
think so.
current
4 and
symptom.
5, not appropriate.
Not appropriate. Okay. Let's share. Okay.
Obviously, remember, we're not doing anything new with the client, right? Not teaching, not new interventions. The client is actively panicking. Who can read?
A nurse on the mental health unit is caring for a client who attempted suicide. Which of the following actions should the nurse take? Initiate continuous observation of the client. Verify that the client swallows PO medications. Provide the client with plastic utensils for meals. Inspect the client's personal belongings for harmful items. Allow the client to temporarily have the unit of accompanied by a family member.
All right, it looks like you guys like from 1 to 4. Do you mind reading, please, Joan? Thank you. Or anyone else who would like to discuss this.
Okay, decline suicide are increase the risk for future attempt and completion. Therefore, the priority is to maintain the client's safety. Safety intervention included placing the client on suicide precautions. Maintain continuous one-to-one supervision by training by a staff member. Closely observe the client during medication administration to ensure the client swallows all the prescribed medication and do not horse the pill. Provide meal tray with a plastic utensil to ensure the client do not have access to the sharp objects that is nice of force that they can kill themselves or to try. Inspect the client's belongings, environment, and items brought in a visitor and remove the shards and potential harmful objects, bells, ties, and glass items. think this question is good. We can move to next one. All right, we have the following. Okay, let's read it. The nurse in the mental health clinic is caring for a 34 years old client. The nurse now state that the report feeling anxious and fearful at work and stay unafraid, and I want my coworkers say about me if accept a promotion. Report feeling self-conscious and reluctant. Okay. Reluctant to try to new activities or attempt social events. Report anxieties in social events and do not leave homes, often due to the fear of rejection from others. For each potential intervention, the client whether intervention is appropriate or not appropriate with the nurse know. Okay, we have the potential interventions, assist the client to identify specific fears. What do you think, guys? Could be appropriate or not appropriate? Hello?
Appropriate.
Appropriate? Okay. Request referral for a dialectical behavioral therapy.
Appropriate.
Dialectical behavioral therapy. Appropriate or not appropriate?
Appropriate.
Appropriate. Encourage the client to participate in assertiveness training. Assertiveness training. I think it's appropriate, right? Recommended eye movement desensitization and reprocessing therapy.
Not appropriate.
Not appropriate, right? And embrace friends and outgoing demeanors when interacting with the client. Appropriate or not appropriate? What do you think?
No. Back.
Appropriate.
Come back.
Appropriate?
Yes.
Okay, let's try. Let's see. Go ahead. Yes, we have the
Okay,
only
very
one that is
good.
not appropriate is request referral for dialectical behavioral therapy.
My friend, my coworkers will say about me if I say a promotion upon feeling
Let's see
subconscious
why
reluctant to
this
try
one
my
is not
activities.
appropriate. Dialectical behavioral therapy is used for clients with borderline personality disorder. It's not appropriate for those that avoidant personality disorder. Clients with avoidant personality disorder should participate in a cognitive behavioral therapy and a social skills.
Very good. I agree. Correct. Because what they need is to change those behaviors to make sure that they learn how to cope in social gatherings or social events. This is a person who doubts themselves a lot, right? This is a person who is afraid of what people are going, the person that's constantly thinking of what are others thinking or feeling about them. They are very fearful of criticism because criticism makes them feel bad because they don't have good self-esteem. They're going to have a low self-esteem. So very important for them to feel, I don't know, accepted. They don't want, imagine this, right? You are a person who are afraid to get a promotion because you don't know what your coworkers are going to feel about that. And then they constantly have that little voice telling them that they're maybe not worth it, or they don't, what if I do a bad job? What if my coworkers don't like me, right? They constantly have this self-talk. So what they need is to change that behavior, cognitive therapy behavior. Very good. Great job, guys. That's not bad.
Okay, let's move to next one. Okay, the nurse is teaching for a caregiver For a client with Alzheimer's disease who experienced neuropsychiatric symptoms, which of the following information should the nurse include? Use visual cue and gesture when giving instruction to the client. Tell the client that has delusion and hallucination are not real. Give direction to the client by focusing in one step at a time during the activities, and remain near to the client and maintain eye contact when speaking, and redirect the client using music and pictures when the clients become aggressive.
All right.
We have a client with Alzheimer's disease who
They
is
have
experiencing neuropsychiatric symptoms.
very good. Fatima just marries like from 1, 3, 4, and 5. So visual cues and gestures when we're giving instructions. Definitely number 2, telling them this is not real. And I'm guessing it's because you guys know that the client doesn't know that is not real, right? And this can cause confrontation. The client believes that what they're seeing and what they're hearing is real. Give them directions by focusing one step at a time during activities. Yes, we cannot. This is not a client that we can give a lot of instructions at once, right? We gotta go little by little, small instructions. I like that. Remain near the client, absolutely, right? Let's talk to them. Let's keep eye contact so they can see what we're saying. Let's be reassurance and calm. Obviously, avoid any possible confrontation. Redirect them, distract them. Yes, that's good. Distraction is important, right? Because again, someone with Alzheimer's, they're thinking about something, they could be very aggressive about something right now, and then you change their attentions. Not number 3, Joan.
No 3?
I'm sorry, not 3. No, no number 2. No for number 2. 3, yes, is a good one.
One at a time is good.
Yes.
Introduction. Okay. Perfect.
Very good. And you will see, and they could become very emotional. And we don't want big emotions in this client. We try to avoid those as much as possible. Big emotions could be agitation, like they can become very agitated easily, but they can become very sad easily and start thinking. I have clients that all of a sudden start thinking about some boyfriend, or maybe some male nurse remind them of their ex-husband, and they literally feel as if they were at the moment when 20 years ago their husband cheated on them and they had to separate and they left them, and they feel literally in the moment, and they talking to you as if so and so just hurt them and cheated, and they go into this full sadness and crying. And then you redirect them. You say, oh, I'm so, you hold their hand, you speak slowly, and then you say, oh, but look, today sometimes it's something as, you're looking so beautiful today. Do you remember? Or ask them about their children, or ask them about something that happened a while ago. Because remember, they have better luck with things that happened a long time ago. They don't really lose that as quickly, right? They're going to lose recent memories, but they're going to preserve memories that happened a while ago. Very good, guys. Using music, yes. Sometimes I ask them about a song. What song do you like? Do you like to sing? What music do you like? Sing me a song that you like. And it's fascinating how quickly they were like, oh, you know what? I like this one. And then they start singing the song, and with tears and everything, but now they're somewhere else. So music and singing and dancing, works wonders. Beautiful, guys. Next. I'm reading this one, okay? Nurse is assessing a client and suspects the client may be experiencing intimate partner violence. Which of the following findings would be consistent with intimate partner violence? Select all that apply. We went over all of them, right? So I think this is going to be a quick one. Withdrawn demeanor, bruises in various stages of healing, untreated sexually transmitted infections, frequent visits to the emergency department, consistent explanation of how physical injuries were obtained. So what do we like? Fatima likes 1, 2, and 3. Hold on, I saw someone else send an answer. Pierre likes 1, 2, 3, and 4. Liliana likes from 1 to 4. I like that, except for number 5. Obviously, remember, in this case, it would be inconsistent stories, meaning the partner says one thing, the patient says another one, or the story keeps changing and changing and changing every time you ask them, or you ask the patient and then is the perpetrator who's answering, right? Very good. Uni, yes, for number 4 as well. What was number 4, Joan? Let's go back, please. Number 4 was frequent visits. Yes, frequent visits, because, they can constantly be hurting themselves, right? And sometimes kind of they think, the perpetrator think that by sending the person to the thank you, to the ER, they're covering themselves, right? Like, oh, she needs attention, let's take him over there. But frequent visits to the emergency departments, with children, this could be common, right? Depending if you have a rambunctious child, but it could also be a sign that something's going on, because obviously this person's being beat up so badly that it requires them to go to the hospital. Very good. And untreated STIs, obviously, yes, because most commonly, if you have an STI, the logical thing would be you're having manifestations, you want to go and seek treatment. Bruises in different stages of healing, very important, because that means repeated abuse, right? So one bruise is healing, and then you get a new punch this week, and then that's going to have a different stage. Remember, the location of those bruises is very important. They're going to be in places that not normally, like, are harder to explain, right? If you fall, usually when we fall, the first thing we do is to try and protect ourselves. So we put our hands to break or fall. We're going to put our knees. We're going to fall into our knees, maybe in our foreheads, right? If you literally cannot break your fall and you end up scratching. But more likely when you're falling, based on where you're falling, your shoulder, your elbow, your hands are the ones that are going to break that fall. It's very hard that, okay, right here, you have a bruise right in the middle of your arm, and then, it looks almost like a hand, and you can see its lines. Hold on one second, guys. Joanne, you can go ahead and keep reading. I'm sorry.
Okay, let's continue to the next one, guys. The nurse is caring for a client who is receiving hospice care. The nurse entered the room and observed the client exposed crying. Which of the following statement is appropriate to make? You seem fatigued. Maybe some rest will help you to feel better. Would you like me to ask the chaplain to come to visit you and your spouse? I'm here for you and your spouse. Is there anything you need? I'm sorry this happening. Would you like your spouse like sometimes alone? What do you think, guys, would be the appropriate statement by the nurse to me? Better.
Let's see it.
Which one you think, guys?
Hospice. So I see in the chat, Joanne. Let me hold on. I see in the chat that we have Fatima, Senia, Marlene. You guys like number 3. If you want, I can get the chat, Joanne, because I know that when you're sharing the screen, we really cannot see the chat. You have to like get out of it. Marie likes number 3 as well. Very
Okay,
good.
let's see. Perfect.
Great job. Absolutely.
I'm here for you, for your spouse, and there is else that you need.
Very good.
Assertive
That is
communication.
when they tell you offer self, right? You're offering yourself, you're offering your support. There it is. Psychosocial support, communicate therapeutically, or offering yourself. Obviously here, hospice is basically, we're telling this, remember the difference between palliative and hospice. In hospice, we are telling this client your death is imminent, right? To meet the criteria, like medically to diagnose it, because you need to basically discharge from care and then putting this patient into hospice care. We still provide interventions, but we're telling this person what condition that you have. There's nothing else we can do. And within 6 months or less, we expect this person to expire. Obviously, it's very emotional on families. You come in, the person is actively crying. Number one, you seem fatigued. She's not she could be fatigued. This could be true, but this is completely ignoring the fact that the client is literally actively crying right now. Number 2 is you're kicking the problem to someone else. Let me bring someone else to console you. Let me bring a priest. No, you're there. Right now, they need someone right at that moment. I am sorry this is happening. Would you and your spouse like some time, or spouse, I'm sorry, like some time alone? Again, you're kind of deflecting, you're leaving, you don't, it says, I don't really want to deal with this. I'm so sorry, but I gotta go. No, right? Offer yourself. Be present, because again, this is mental health, but this client is in crisis right now. And remember, we never leave a client alone that is in a crisis or that is unstable. This is a client who's unstable. And when it comes to hospice care, we don't only care for the patient, because in reality, the patient is dying. The majority of support when there's a death or when there's hospice comes from supporting the family, because this is going to be especially particularly hard on the family. All right, guys. Let's if you guys still good? You want to continue? You want to break? Tell me. Because we can do this question, then we switch and maybe take a little break and keep going. If you guys are okay, I have no problem. Keep going. If you guys need a break, you want to send me in the chat what you think.
The nurse is assessing let's read this one, okay?
Okay.
The nurse is assessing a client with social anxiety disorder. Okay. Which of the following findings would be consistent with that condition? Okay, how be consistent with that condition?
Select all that apply. And remember, social anxiety disorder, which is, again, falls into the anxiety disorder, but this one specifically when it comes to social, which is the key word there. I see you guys like Pierre, Rosangil, Fatima, Jessica, Liliana likes 1, 3, and 5. All of you kind of unanimously like those 3 options. Very good. Great job, guys. Absolutely. So consistent is physical symptoms, because remember, there is a sympathetic response when a person has to be on a crowd. Maybe they have to talk to a crowd. Maybe they have to talk to a meeting. Maybe they are in an event in which they feel that there's a lot of eyes on them. They're going to have physical symptoms. Again, it's activation of the sympathetic nervous system, trembling, flushing, diaphoresis. You're going to see this client sweating profusely, difficulty breathing, palpitations. They are literally going to feel that their heart is pounding out of their chest, difficulty concentrating, speaking, and performing, nausea and abdominal pain. Absolutely. This condition is going to bring physical manifestations to this client. So let me see. Do you guys want that break? Send me in the chat. What do you think? I don't see anything. Tell me, guys, do you need a break? Or do you want to just keep going?
The realistic behavior is for the obsessive-compulsive disorder.
Ritualistic, yes. Remember, it's a
Yeah.
ritual, right? In which they do. What is a ritual? Usually a ritual is something that we do over and over and over again, like a routine.
Yeah.
So, like we said, every person has a routine. You wake up in the morning, or maybe when you come home from work, right? Like my ritual is, number one, I leave my shoes at the door. I don't want to bring whatever my feet were supposed to in the hospital home. So I remove that. I remove my jacket or whatever external cover I had, leave it there. The very first thing before I even have my kids come and hug me is remove everything, put on a bathrobe, and then I say hi, and then I put on hot water, take a bath, clean my face, remove all the colonization that I had from the hospital, maybe a little bit of a facial, whatever, right? We all have little routines. In the case of OCD, obviously this is excessive. This is the client that feels that before they leave the house, they need to touch the doorknob 10 times. They need to check on the stove 5 times. They need to wash their hands with like boiling hot water because they feel that that's the only way they're going to kill germs. They need to touch a doorknob sometimes, or touch a wall, or I don't know, something that they think in their head they had to do in order for them to have a good day, or in order for them to relieve the anxiety. It's a ritual, a ritualistic behavior, something that they do over and over again. All right, so let's change. Joan, you want to change now?
Yep.
Okay, I have an exam ready here. Let me open this exam. Done. We are okay. Let's do this one. Oh, this is a pharma. I don't know if there's only pharma or if there's a little bit of everything. Very good. Can you guys see my screen?
Yes.
Very good. Okay, who wants to read this one? Nobody? Come on, guys. There's 41 of us. I hope that you're really here and not that you're just here because of the attendance, but you are watching Netflix right now. So don't be shy either. This is, like I said, this is a more chill, more relaxed. It's, participation is the key of a study group. And I know I talk a lot, but I want you guys to participate too.
The nurse is reviewing prescriptions for a 84-year-old client with type 2 diabetes mellitus, hypothyroidism, heart failure, and hyperlipidemia. Which of the following prescriptions should the nurse clarify?
Love this
Glyburide,
question.
furosemide, rosuvastatin, and levothyroxine.
Love this question because this is similar to what the Nclex said. Identify the medication that does not belong here. based on these conditions. They have diabetes, hypothyroidism, heart failure, hyperlipidemia, so they should be taking medications for those conditions. So there's one there that doesn't belong.
Levothyroxine.
Number 1.
Glyburide. Do you guys agree? Because I heard someone else saying maybe number 4.
Number 2 is for heart failure. Number 4, levothyroxine, is for the hypothyroidism. And then
Very good.
hyperlipidemia, rovastatin, so I think is
It's a
1.
statin, right? Very good. Very good. Great job, guys. Now, why not? Let's see what this client has. Type 2 diabetes mellitus. And I think you probably, let's see. Medication recommended by this criterion, so the medication should be. Why? Because it's a sulfa. And this person has type 2 diabetes. So we're like, wait, why can they take a sulfite and a sulfite to treat, to help with diabetes mellitus? The reason why is because this is one of those medications. The sulfa medications are the ones who's had a very, very high risk of causing hypoglycemia. Now, remember, there are certain medications when we talk about medications that can mask the symptoms, although I don't think any of this fall into that category, that they mask the symptoms of hypoglycemia, so the client really don't know if they're having a hypoglycemia and their sugar could be dangerously low. But specifically for these clients who are 84 years old, who's an old patient, who might not necessarily present with the marked signs and symptoms of hypoglycemia, we should be very, very careful with giving those medications, because they could have, I have seen clients with glucose of 28 and the diaphoresis and the shakiness and all the things that you expect, you won't see it. All that will tell you is that they feel a little tired. And then you go and you check the glucose and it's 28. And there's nothing, there's no shakiness, there's none of that, especially for elderly patients. So very, very, very important. But it's specific for what I was saying, the fact that this client is 84 years old. There's something that is called the Beers criteria of medications that we should avoid in those elderly patients. Who's too elder? I mean, I think mid-70s, you should consider your patient elderly, right? Even in the 70s, but with most caution. Remember, this is the client who has impaired elimination. They might have a lower, might start having issues. They might have lower metabolism, issues with the liver, issues with the kidneys, all medications that are that can accumulate, especially if the client has a hard time with the excretion process. Anticholinergic medications, especially first-generation antihistamines, medications for GI, antispasmodic, your alpha-1 blockers as antihypertension, centrally acting alpha-2 agonists, many antiarrhythmic medication we should give carefully. Remember we were talking earlier about Haldol. Haldol is one that should definitely refrain from giving that to elderly patients. No good. Maybe try something else. Your TCAs, your antipsychotics, like I just mentioned, barbiturates, benzos, and other hypnotics. And when you have experience, you know that doctors would be very reluctant to give you a prescription for that. Long-acting sulfas, sliding scale insulin, NSAIDs, and skeletal muscle relaxants. A sliding scale insulin, remember, is the scale in which you said, okay, my patient has, I don't know, they give you a scale, and if your glucose is, for example, between less than 150, you don't need to give anything. But if the sugar is from 150 to 200, you give 2 units. From 200 to 250, you give 4 units, and so on and so forth. Because you'd be surprised. You may have a client who's like, I don't know, 155. You give them 2 units of insulin, next thing you go and come back, and now the glucose is 70. So, because again, it accumulates, they cannot excrete properly, and then it just becomes major. Bears criteria, again, identify medications that are inappropriate for older adults because, yes, there's too much risk. There's not, we always do everything with benefit outweighs risk. In this case, it doesn't, the risk is too great. It doesn't outweigh, the risk definitely outweighs the benefit. We want to minimize giving this medication. Obviously, there'll be some cases in which you absolutely have to give this medication. Remember, you can collaborate with the pharmacy and say, hey, can you give me a renal dose? Meaning we're not going to give this patient the regular dose that we would give a typical patient. They might get a reduced dosage or they might get an adjusted schedule just to minimize this effect. Or you need to be prepared that if you can give something that can cause an altered mental status, it can put this client into a higher risk for falls. You got to make sure that you maybe get a sitter or you maybe sit this client right across from you so you can actually see them. Again, sulfas like glyburide stimulate insulin release by the pancreas. And please learn all the medications in this category because they probably will ask you about that again, because they have the higher risk of causing severe hypoglycemia, especially in elderly patients. Again, the risk is because they have delayed elimination. Bears criteria tells us that. So we should use other medications. Obviously, we need to treat the type 2 diabetic medications. With the type 2 diabetes mellitus, but we're going to treat it with medications that does not cause this severe hypoglycemia. Let's see what else. For example, metformin. Good. Furosemide, we say yes, we use that for the heart failure that the client has. This is a diuretic. Caution, obviously, with elderly clients would be electrolyte imbalances. They can go and develop low sodium quickly. Statins that we know is for the hyperlipidemia. The important thing there, for example, elderly clients like grapefruit juice. Maybe not so much Hispanics, but white people do love their grapefruit juice. They should not be taking grapefruit juice with statins. Very important. Remember, rhabdomyolysis. This can happen. And how do we know? Your client starts using, it starts peeing and is dark brown. And then all of a sudden, maybe before they pee brown, they tell you, oh, my whole body is like aching. I feel sore like if I work out. It's a little red flag. And levothyroxine, yes, we're going to give that for the hypothyroidism. Great job. Next. Who wants to read? Nobody? Come on, guys. I know you're here. You guys are here. You're giving me answers because you're reading. Please read out loud. Nada? Nadie? Okay, I'll read. Client with generalized anxiety disorder receives a new prescription for sertraline. The nurse should provide teaching to the client on what possible adverse effect of sertraline, which is the family of this medication. You guys are giving me answers. This is A. So it's a hypernatremia, sexual dysfunction, urinary retention of weight loss. You guys are sending me a lot of number 2s because this medication is a what? What kind of medication, guys?
SSRI.
Very good. Great
SSRI.
job. Very good, Liliet. Thank you so much. Is Liliet? No, Lilivet. Thank you so much. It's a serotonin reuptake inhibitor. SSRI. Basically, this explains how they work. Basically, one of the reasons why these medications take a while is because they work by not making more available, but making they make the receptor, like the accumulation. They have to accumulate right here, right? And that accumulation takes time. It needs to build up. You need to build up all that serotonin, allow the serotonin to accumulate. Like I said, that accumulation takes time, which is why we educate the patient that when they're taking this medication, they're not going to experience relief. They're not going to start feeling better right away. Because a lot of the patients will call and tell you next week that you call them for a follow-up in 2 weeks. Are you taking the medication? How's it going? No, I stopped taking it. Why? Because it wasn't working. I'm still feeling sad. And then we're going to say, wait a minute. This medication doesn't work right away. Remember, it takes time. It can take 4 up to 6 weeks, maybe 2 to 3 months for a person to see full effect of this medication. So it's important for the patient to have patience and to not stop the medication simply because it's not working right away. They're not going to see the effects for a while. Let's see what else. Serotonin reuptake inhibitors. We have selective serotonin reuptake inhibitors or SSRIs and your TCAs. These are the serotonin receptors. So what they do is they kind of block you see the reuptake transporter. What they do is basically they see serotonin here and they just take it back, take it back, take it back. We block that so they don't take it back. When they don't take it back, then it accumulates right here, and then it becomes more available for those serotonin receptors. There's more serotonin available. Very good. Great job, guys. Important here, yes, this can induce hyponatremia, no hypernatremia. This is, again, transient. So when does it get better? As soon as you stop the medication. But keep in mind, it's a medication that we cannot stop suddenly. You need to titrate the client. We definitely want to order complete metabolic panels on these patients routinely to see if it's affecting the electrolytes. And if it is, then remember we need to make the client, doesn't mean the client can need to discontinue. If the SSRI is working, what we do is usually dietary interventions. Have the client eat more chips, a little bit more salt, anything to help them replenish that potassium, because we also don't want them with a severely low, not potassium, sodium. Very good. Yes, the sexual dysfunction could be a reason, especially for younger patients, to be non-compliant with treatment. Because a younger patient, obviously, they want to have a good sexual life. And if they find themselves finding a girlfriend or a significant other, someone who is making them feel better and come out of that depression, they could be inclined to stop the medication because they want to have sex. So important to educate and say, okay, maybe it's not a good idea to completely leave this. Maybe we can use a different category of medications, but don't stop it suddenly. Again, we use this for major depressive disorders and anxiety disorders as well. I was telling you it can be used not chronically, right? It can be used to treat the premenstrual syndrome, the PMS. In that case, the patient doesn't take it often, right? They're just going to take it like a few days before their period or before they're ovulating, so they can kind of avoid it, but they don't need to take it daily, right? They usually more acutely. Very good. Great job, guys. Next question. Healthcare provider prescribe phenazopyridine hydrochloride for a client with a urinary tract infection. The key for this medication is these 3 letters, AZO. AZO. For a client with a UTI, what would the office nurse teach the client to expect while they're taking this medication? You're going to expect constipation, difficulty sleeping, discoloration of the urine, or, a dry mouth. And all of you seem to like number 3, discoloration of the urine. Very good. Yes, the urine is going to turn really, really orange, really bright red. Tell the client don't alarm themselves, maybe to wear on like a little pad to protect in case there's a little leakage, they don't stain their underwear. Very good. Remember, It's important for this medication is that this medication is going to provide pain relief, but it's not going to treat the UTI. So very important to take the client to complete their antibiotics. Sometimes they sell this kind of medications over the counter. Doesn't mean that, oh, you're going to take it, they feel better, but they still have an infection even though they don't feel the pain. So we need to educate the client. You still need to go to the doctor. You still need to get tested. You still need to do your full run of antibiotics because even though this removes the pain, it's not removing the infection. And obviously, always with antibiotic, we need to educate the patients. Please finish them, even if you're feeling better, to avoid the development of the superbugs. The nurse had taught a client with panic disorder who has a new prescription for alprazolam. Which of the following statements by the client would indicate a correct understanding of the teaching? And I should eliminate aged cheese and processed meat from my diet. I can continue to take my prescribed muscle relaxant as needed. I can omit the medication on days when I do not feel anxious. I will notify my healthcare provider if I become pregnant. Again, alprazolam. And correct understanding, which means yes, this is correct. So there are 4 statements incorrect. Only 1 is true. And I have Thyme likes number 4. Pierre, Jessica, Gwendolyn, Rosangil. Is it Rosangil? Marlene. And Thyme likes number. Wait, Thyme actually says no, sorry, it's number 3. It's not give me 1 second. You can have a seat. It's not, remember, correct understanding, meaning, yes, whatever is true. You guys are saying, I will notify my healthcare provider if I become pregnant. Okay. Wait. Okay, now Tommy is saying 4. I can remove the medications and days I don't know feel answer. You should notify the healthcare provider. Yes, so I guess you guys do agree that the correct thing is yes. We're going to talk to the healthcare provider if we're pregnant. So let's go back. Let's see one by one. Should eliminate aged cheese and processed meats. Which category of medication is that we avoid this? It's teratogenic. Good timing. There are a category of medications that are used for mental health. Very good. The Maui and Maui. Very good. Which we want to eliminate this. We know that alprazolam is not a Maui. Very good. Continue to take a muscle relaxant as needed. Can you take a muscle relaxant with one of these? Probably not a good idea, right? We don't want to mix those. Can omit the medications on data, do not feel anxious. We just said that earlier, right? We don't want to discontinue this suddenly. This is not a PRN because, again, remember, it needs to build up. It takes time. It's taken PRN, yes, in the case of premenstrual syndrome, but this is not the reason why this person's taking it. This person's taking it for panic disorder. So very good. Great job, guys. Yeah. I'm sorry. Yeah, this is a benzo. It's alprazolam. It's a benzo. Very good, Marlene. Benzodiazepine. But again, benzos is the same. The reason why sometimes we don't run into benzos is because benzos have a high probability of causing addiction, right? The person can become dependent on this medication and, carefully we give them, again, benefit outweighs risk, but this can definitely cause addiction. Again, yes, your LAMs, alprazolam, your clonazepam, central nervous depressants, none of these medications. Usually, as a good rule of thumb, mental health medications, most of them you do not want to discontinue suddenly. So that applies for all of the categories. You want to taper down. What else? They work by potentiating GABA. GABA is the one that depresses the excitatory neurons. It can make the person feel sleepy, sedated. You feel like you're just in a good place. But the sedation comes with safety risk. So very important, especially at the beginning of therapy, this person should not be driving, should not be operating heavy machinery. They probably should not be able to do anything that requires a lot of concentration and a lot of alert and awakeness. Let's see what else. They are effective in treating anxiety, insomnia, seizure disorders. Like I said, they are used usually short term. We don't want them long term because of the potential for abuse. They are teratogenic, so we don't want to use them if the client is pregnant or is planning to become pregnant. You definitely need to tell your doctor if you're planning to become pregnant or if you are pregnant. If you are pregnant, then yes, discontinuation is granted. Usually, it's not going to be cold turkey either, right? Either they're going to give you an alternative treatment or we're going to start getting you off little by little. Tyramine containing foods, the aged cheese and all of that, again, those are your MAOIs. Remember that it interferes, not necessary for benzos. Should not be mixing benzos with CNS depressant like muscle relaxants. We do not want to combine that. And let's see what else. Yeah, again, we need to take this exactly as it is prescribed. They should not be omitting doses. This is not a PRN medication. Very good. Like I said, we can use a short term, for example, in the case of your opioid withdrawal, no, alcohol withdrawal. But again, probably should start slow and build up. And then when they're taking it off, slowly until you completely get the client off of it. Next one. Nurse is teaching a client with hyperlipidemia has a new prescription for simvastatin. The nurse should instruct the client to take simvastatin in the afternoon with a snack, at bedtime without regard to food, in the morning on an empty stomach, and at noon immediately following a meal. You guys, Marlene and Timmy likes number 2. Remember, this is working on cholesterol, and it is said that cholesterol is, can get better effects if you take this at night. This type of medication are your statins or MGCoA reductase inhibitor. Your keyword here to remember them, again, that's why they call the statin, because usually they old and with that suffix statin. The purpose to give this is to lower cholesterol to help prevent atherosclerosis, obviously for your client who has a high risk for coronary artery disease. If your client has hyperlipidemia, we want them to take this medication. We talk about the potential or the more severe complication being rhabdomyolysis. We talk about giving it, hopefully avoiding grapefruit juice, paying attention to the complaints of the client. Although rhabdomyolysis is not too common, again, it is always good to tell the client what to expect. If all of a sudden you are waking up one day and your muscles hurt, as if you run a marathon and you feel completely sore and you feel like all this pain everywhere, it's a potential indication that there could be, potentially this could happen. So it's always good to educate the client to, what you watch for. Again, the reason why we give it at night is because that cholesterol is synthesized by the liver usually at night. So that's when it will be more effective. It will be greater reduction on that bad cholesterol if we take it at night or at evening before bed. If it causes you an upset stomach, like any other medication that could potentially give you an upset stomach, yes, it is recommended to take it with a meal. But taking this medication with food can help, reduce that irritation. At this one or any other one, right? Unless absolutely contraindicated and it tells you to take it on an empty stomach. If it gives you GI disturbances, taking it with food makes it a little better. All right, nurses providing discharge instructions to a client who is receiving oxybutynin for an overactive bladder, which client statement indicates that further teaching is required. So in this question, everything is correct except for one option. That is our answer. I am looking forward to our summer vacation at the beach. I plan to eat more fruits and vegetables to prevent constipation. I should not drive until I know how this drug affects me. I will drink at least 6 to 8 glasses of water daily. So one should not do. I always remember Bajin with the can see, can pee, can't poop. Who told me? Timey, you said number 1, right? Tell me why. What kind of medication is oxybutynin? What category of medications? Where does it fall? If you don't want to open your mic, you can send it in the chat, Tammy. Antispasmodic, very good. And that antispasmodic causes, the reason why you're saying this is because it causes what? For the sun? Jaimara,
Sensitive.
photosensitivity, very good. Great job. Photosensitivity. So a vacation at the beach is going to make this patient get probably a horrible sunburn, right? I'm sorry, Jaimara, what form you talking about? You talking about the attendance? And if it is, it could be, is it because you are on the phone maybe? Are you trying to open it on the phone? Because sometimes it doesn't work on the phone. So if you open it, even if you maybe open it a little later, maybe copy and link, copy and paste it. Copy and paste it, is that what it is? I don't know, Jaimara, send me in the chat or open your mic and tell me. What form are you talking about? You're talking about the attendance link. What happened? Dime. Okay, Jaimara, I don't know. Send me a message and tell me what forms are you talking about. Sorry, because I really don't know what forms you're talking about. All right. Okay, oxybutynin, anticholinergic. That's what I was telling you about the can see, can pee, can poop. Those are your anticholinergic medications. All anticholinergic medications, again, you're going to block acetylcholine. This is kind of funny too, but if you remember Professor Begin, or if you've never taken, I'm sure almost everyone knows who Professor Begin is. If you don't, please, I highly recommend that. He's a genius. He's fantastic. He would say crazy people, even though in this case, they're taking it for overactive bladder, but he says crazy people because a lot of the people who have mental health medication, mental health conditions could possibly be taking anticholinergic medications. It says they don't go to the beach. Mental health patients don't go to the beach. Why? Because most of those medications are going to have or to cause photosensitivity, which means that 5 minutes out in the sun leads to a complete, to a really, really bad sunburn. Heat intolerance. Again, anticholinergic can see because it can cause you blurred vision. Can pee, it can cause urinary retention. Can poop is going to cause constipation. It's going to cause cystostomia or dry mouth. It's going to cause you flushing in the face. Again, that photosensitivity and possibly drowsiness. So again, not a good idea for this patient to be driving and operating heavily machine, which is why, yes, it's okay for them to not drive until they know what's going to happen. Eventually, they can, some of these side effects will get better. And maybe, it's only the initial doses that's going to cause a little bit of dizziness or drowsiness. And then as the body kind of get used to them, they get better and they are able to drive safely, but not at the beginning and not when there is a change of dosage, especially a change of dosage, meaning the doctor is increasing the dosage, because then again, the symptoms are going to go back. How do we treat dry mouth? Drink water throughout the day. Get some gum, sugar-free gum. And the important thing with gum, if they offer you sugar-free, it's probably a good intervention. The problem that there was with gum was the sugar, right? That you're constantly chewing on that sugar and it can cause cavities and dental problems. If they say sugar-free, then you eliminate the sugar part that was the problem with the gum. So if it's sugar-free, it's usually safe. For the xerostomia, obviously glasses, maybe a little bit of drops, right? Some drops that can help keep your eyes moisturized. The reason for the hyperthermia or the heat intolerance is the decreased sweat production. You should tell them to be very cautious in hot weather because they can overheat. And again, they can also get that photosensitivity. They can develop severe rash. Not rash, I'm sorry, severe sunburn. Eliminate rash, sunburn. If they get a rash, we need to worry because that could be Steven Johnson's or it could be an allergy. Remember, people who are taking mental health patients could develop Steven Johnson's. So Steven Johnson's is just this severe reaction that usually will start with a little rash and then it becomes generalized and it's almost like a full burn. Great job, guys. Next question. It says this question has been deactivated. If you encounter this, it could be that either they're not giving you the points that you need, or it could be that most of the time I find that the question has already been fixed, but usually the question is correct. But let's see, or the points are incorrect. The nurse in the emergency department caring for a client with salicylate toxicity. The nurse she prepares to administer. So basically they're asking you for the antidote for salicylates. Vitamin K, flumazenil, protamine sulfate, or activated charcoal. What is the antidote for salicylate? And you guys are saying is activated charcoal. Marlene, Gwendolyn, and Thymine. Guys are on fire. Great job. Very good. Oh, I like the photo. Let me see if I can take the screenshots myself. Sometimes I can, sometimes I cannot. Oh, here, now I can. Very good. Again, why I like pictures, look at this picture. This picture has pretty much everything on it, right? So you have your manifestations by system, which is the way that the Nclex is loving to ask now. They may give you a scenario. I got that for the first time. When I saw that question, I was like, oh my God, because literally they give me every single system and you have to select at least 2 manifestations per system that apply to that case scenario that they gave you. So very important to know. In the brain, can give you tinnitus. If you don't know what tinnitus is that beep that you feel every once in a while. Dizziness, altered mental status, cerebral edema, and seizure. They might not tell you cerebral edema. They might not tell you cerebral edema. Remember how one of the first manifestations of cerebral edema could be a headache, right? A pounding headache. Dysrhythmias of the heart, tachypnea, pulmonary edema, nausea and vomiting, hepatitis, arrhythmias, metabolic acidosis, and fever. Very good. So salicylates, obviously, you know your salicylates is your aspirin, anything that's derived from salicylic acid. Sometimes people who take, how do you call that, Alka-Seltzer? If they suffer from an upset stomach and they just take a lot of that, they could develop this. NSAIDs, your NSAIDs, of course. And antiplatelet medication can lead to disintoxication. Sometimes people do it purposely, you know, in an attempt of suicide, right? They just grab whatever pills they find and they take them. We talk about the manifestation by systems. What do we give? Activated charcoal. Initial treatment for clients with salicylate toxicity. What we want is obviously limit the absorption of the body. We want the body to not absorb this, to reduce or to minimize the absorption of the salicylates. We want to promote elimination. We can also use this for clients who have salicylate toxicity, but they don't have any symptoms. Obviously, we want to, that would be the best case scenario. We want to prevent symptoms, so we're still going to give it to avoid and prevent those symptoms. Remember vitamin K, which one is it for? Vitamin K is the antidote for
Warfarin.
warfarin. Great job. Flumazenil is the antidote for,
Benzos.
and protamine sulfate is the antidote for.
Heparin.
Very good. Great job, guys. It's gonna be about 1:30. Let's see if the next question is easy. If not, we can stop. Let's see. You guys want to do this one and we finish? Let's do this one and then we'll be done for today.
Okay.
Okay. Thank you for, I want to hear your voice. Thank you, Taimi, for opening up your mic. We have nurse preparing medications that are due at 18 hours for a client who had an aortic valve replacement 5 days ago. Which action should the nurse implement first? Now, there's an exhibit. Let's see this exhibit. So we have the MAR. This is part of the client's MAR. They're telling us that the client has no known drug allergies. The medications that are scheduled are levofloxacin, 500 milligram by mouth once daily at 9 o'clock. Potassium chloride, 20 milliequivalents by mouth once daily at 9 o'clock. Docusate sodium, 100 milligrams by mouth once daily at 9. At 1800, we have warfarin, 5 milligrams by mouth. And simvastatin, 20 milligrams by mouth once daily. So what are we going to do? We assess the client the most recent potassium level. We check the client's RNR. We measure the client's vital signs. We verify the client's medication allergies at the bedside. So again, the medications that we have to give now are warfarin and simvastatin. What do we do before we can give those two medications?
Check the INR.
Like that. PT and INR for warfarin. And APTT, if you're giving what?
Heparin.
Yes, I'm ready for the love this. Very good. And remember, client on warfarin, obviously, for it to be therapeutic, your client should be between 2 to 3. However, because remember, when we're doing anticoagulation, there's going to be different ranges based on the client condition, based on the reason why we're giving this anticoagulant. If it's to prevent DVT, they're going to be on one range. If it's, for example, like this client who had an aortic valve replacement, they replaced a valve, especially recently, this client is going to be in aggressive anticoagulation for at least 6 months. Probably on more than one anticoagulant, because we definitely want this valve can cause clots. We definitely want to prevent, so this client is going to be in severe. For this client, you probably don't want the 2 to 3. Remember, normal anticoagulation around 1.1, right, for you and I. Your client, again, who is on anticoagulants, you want them between 2 to 3. The client who had a valve replacement, higher anticoagulation, you probably want this client between 3 to 4 INR. So if this client is less than 3, that's not good. That means the doctor needs to increase the dose. We want them in proper anticoagulation. Obviously, if it's more than 4, the dose needs to be reduced because then the bleeding could be too much. Very important to check, because if your INR is higher than 4, you need to, like I said, hold the dose because it's too anticoagulated. Usually hospitals have protocols that tell you what to do. If it's higher than 4, they will tell you, okay, hold the dose for 4 hours, for 6 hours, for 10 hours, and then give the next dose. If you're on heparin, obviously, if you're not on goal, meaning your client is still not in the proper anticoagulation rate, you Most likely, if it's a drip, you need to increase the dose, and the protocol will tell you what it is. It says maybe, oh, increase by 2 and check the INR again in 4 hours. And then in 4 hours, you're going to check, am I in goal? Yes. Do we stop it? Maybe the heparin monitoring is going to say, wait, no, we need to check. Keep the dose that you're in, but we're going to check APTT again in 4 hours. If you have 2 goals, at least this is the protocol that we have in our hospital. Again, different hospitals might have different protocols. If you have a goal twice, meaning twice the patient is within that range, let's say it's between 44 and 75, I don't know. The client is within that goal and your PTT comes twice on that goal, then you don't need to repeat at PTT in 4 hours. You only need to do once every morning, okay? Very good. Same with the heparin. With the warfarin. You're going to have a protocol that you must follow based on the goals of anticoagulation. So important. It's different, the level of anticoagulation for DVT that it is for valves. Usually when there is a valve, especially mechanic valves, you want higher anticoagulation, so your number is 3.5. If it's on heparin that they're going to put this client, then it probably would be on the higher end, which I think is between 44 and 72. So the higher level of anticoagulation. All right? Very good, guys. I love to see so many people here today. Thank you so much for joining me. Do not forget to sign your attendance. If you're having a hard time following the link, it's probably because you're on your phone. Sometimes it doesn't work in the phone, so try and open it in the computer, okay? Thank you very much for joining me today. Do you guys have any questions? Lizzie, so good to see you. Love you long time. Lizzie is actually an RN already, but she loves her study groups and she wants to keep preparing because I think she wants to be an FMP. If you want to be an FMP, the content is the same. You just got to build on it so you can still come and join us. Thank you so much. I hope that next time you guys get the shyness off and you start opening your mics, telling a story. This is a fun place you can talk and tell us things. All right? Have a great day. Please keep studying. Trust your knowledge. You got this. Every single one of you. Good, positive thinking. I know it sounds cliche, but look at yourself in the mirror and say, I got this. I'm going to beat the Nclex booty. You got it. You're this close. All you need to do is trust what you have, build on what you have, be confident. You guys already did 2 or 3 years of schooling. You have the knowledge. You just need to access it. Trust in yourself. We can all do it. I'm very proud of you. Thank you for coming. I'll see you guys tomorrow. Don't forget to sign your attendance. You guys are the best. Have a great day.
Thank you.
You're very welcome, Beatrice. You're very, very welcome, guys.